I have spent a lot of my life working rural. Today's talk, I wanted to tell you a little bit about some changes in the way that psychological strategies work, but just to give an idea, can I get you to raise your hand if you've got mental health skills training already? If you're writing mental health treatment plans, you probably do. Yeah. Medical students? Anyone? Yep. Registrars? Okay, who's got a psychologist in their town? Who's got access to a psychiatrist that people can actually pay for? Notice me keep my hands down. The private psychiatrists in Canberra run at about $800 an hour, and they still send patients back to me saying this patient is too complicated, I'm not prepared to see them. Unbelievable. Anyway, I won't do that. Okay, so things have changed in the worlds of focused psychological strategies. So for the benefit of the medical students and for those of you who came in, I just want to give you a very brief summary. Way back when, about 15 years ago, the government decided after the third mental health plan that maybe it was a good idea that we didn't just focus on people who were inpatients. Maybe we should look at depression and anxiety. But they realised that if we paid psychologists, we'd bankrupt the system within 5 minutes. And so we started this better access process where GPs were able to write a plan that then gate kept access to psychological sessions and also enabled deeper rebates for psychiatrists so that hopefully patients would get better care. So that was the whole idea. They had two reasons for it. One is to control the funding. The second reason is to make sure that we didn't send patients to psychologists with, thyroid disease and anemia and all the other things that could occur. It's morphed in many, many spaces, but basically what we have now is we have the level 1 training, which is mental health skills training, which is the bottom level, which most registrars these days get. We've got about 85% of our GPs around the country. I'm looking at Bridget, who's in the Secretariat, she's got better numbers than I do, who have level 1 skills training and do mental health treatment plans. But there's a second level called focused psychological strategies where you can get additional skills in psychology and actually deliver the therapies. Now, as a person who runs both training programs, so I've run level 1 and level 2 for 15 years, I've got to say that I don't have level 2 accreditation, but I think I'm changing my mind. So I want to talk to you today about focused psychological strategies and why I think it's helpful. Are the skills helpful? No question. Is it helpful to gain these skills? Absolutely. Is it helpful to have access to the item number? It might be now. It probably wasn't so helpful a little while ago. So I wanted to talk a little bit about who the Mental Health Standards Collaboration are, what focused psychological strategies are and how they're done. So the Mental Health Standards Collaboration, I'm just going to show you a very short video because it's easier than me rabbiting on. So hopefully it'll work and we'll see where we come from. But I'm one of your ACRA members on that particular committee and have been so for 10 years. We're thinking. Oh, magic.
The General Practice Mental Health Standards Collaboration is an independent, multidisciplinary body whose primary role is to develop, promote and maintain standards for mental health education and training for GPs. It includes representatives from general practice, psychiatry, psychology and the community, and is managed by the Royal Australian College of General Practitioners. Along with the RACGP, member organisations include the Australian College of Rural and Remote Medicine, the Royal Australian and New Zealand College of Psychiatrists, the Australian Psychological Society, and consumer and carer representatives nominated by Mental Health Australia. The strength and success of the GPM HSC lies in the collaborative approach it takes when setting standards, which is crucial in promoting the vital role of consumer and carer input. In addition to setting standards, the GPM HSC promotes GP mental health training and continuing professional development, develops resources to support GPs to provide mental health care services, provides updates on current issues in mental health care via conference exhibitions and a quarterly e-news, and contributes to the development of policy in general practice and primary mental health care. The General Practice Mental Health Standards Collaboration was established in 2002 and was included as part of the Better Access to Mental Health Care initiative introduced in 2006, tasked with improving treatment and management of mental illness by increasing community access to mental health care. The The GPM-HSC is the accreditation body for providers of mental health education and training for GPs, including mental health skills training and focused psychological strategy skills training. Upon completion of training, GPs supply their provider number to the GPM-HSC, who reports it to Medicare. Those GPs are then eligible to access additional mental health service items on the medical benefit schedule. In-house mental health treatment provided by GPs increases equitable access to care and further enhances the role of general practice at the forefront of evidence-based primary mental health care in Australia. To discuss mental health education and training for GPs, or for further information about the work of the GPM-HSC, contact the Secretariat or visit the website.
So the reason I put that up there is Molly Shorthouse, who you might know, who's teaching mental health tomorrow, me, who's teaching about childhood trauma tomorrow, and Mike Eaton, who's been teaching REST, are the three ACRM people who sit on that committee. I know it's standards, I know it sounds boring, but what we've protected you from, just letting you know, are courses that have been raised that have been funded by drug companies, courses that teach GPs about psychiatry but don't get general practice, courses that are trying to raise money for certain people, that sort of stuff. And we've tried anything that's on the Mental Health Standards Collaboration website meets the standards for to be appropriate for GPs in rural and remote. So it's a good place to go to get mental health training. And we do often get asked to comment on things like the MBS review, for instance. There's a few other things on the website that you might want. Treatment plan templates for those of you who need them. Particularly the one that people don't often have is the one for child and adolescent, which is quite helpful because the normal treatment plans aren't so good for adults. We've got training of resources from training providers on specific areas. So if you want to go look through the CPD, there's stuff on suicide prevention, there's stuff on social phobia, there's all the extended perinatal, all those sorts of things. We've written a suicide prevention and first aid resource, and certainly we've written another resource for rural and remote. So go onto the website, have a look. There's quite a bit there that's actually quite helpful. So the rule is once you've got your mental health standards, once you've got your mental health skills training, you can decide whether or not you want to learn extended skills. Now, why would you want to do that and what are they? There's 4 particular techniques that are taught under mental health skills. Why? Because the focused psychological strategies have to be evidence-based, and these are the 4 that Medicare have decided are evidence-based enough for us to teach. Okay? So psychoeducation is e-mental health and other mechanisms, and it usually gets woven into everything, so you don't do that by itself. But generally speaking, the providers provide a 20-hour course, because that's the minimum, either around cognitive behaviour therapy or around interpersonal therapy. I'll explain the difference. There is provision now in the MBS for narrative therapy because there is some evidence for using narrative therapy for Aboriginal and Torres Strait Islander people. It's the way that I guess it has echoes of yarning in it, and I'll talk a little bit about that in a minute. So if you want to deliver focused psychological strategies, you sort of pick one. Now, most of us who do this sort of work don't pick one, but we train in one, if that makes sense, in order to get the qualification. So what are they? So CBT, don't forget the behaviour therapy component. So the behaviour therapy component includes, anything for toddlers, anything for parenting, anything with star charts, anything for people with intellectual disability or dementia. It's about trying to encourage behaviours that are helpful and discourage behaviours that are unhelpful. And those techniques are also particularly helpful as part of motivational interviewing, which of course turns up with substance abuse, so that's quite helpful. Cognitive therapy looks at changing people's thinking, so it's about when people over-interpret situations. So the way I always describe it when I'm teaching is, 3 teenagers come into a room and they all say hello to a girl and the girl doesn't answer back, and one of them is incredibly upset and the second one is really angry and the third one is just normal. What's the difference? The first one is incredibly upset, said, "It's what I'm wearing, I knew I shouldn't have worn that." And she hates me, it must have been something I said on Friday, and oh my God, everyone hates me, right? The second one who's angry goes, "She's so horrible, she never talks to anybody, she's so up herself, da, 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 da." And the third one, of course, says it's noisy in here. The aim of cognitive behaviour therapy is to get to the way people are thinking and to try and shift that so that they think more helpfully about their situation. Does that make sense? And there are a whole range of techniques on how you do that. It sounds simplistic in its outline. There's a heck of a lot of evidence for its efficacy in a whole pile of things, including chronic pain. Does it solve everything? Is it the magic panacea? No. It's another tool for your toolbox, like anything else in medicine. Relaxation therapy is a part of that, anger management, social skills training, all those things fit in under the CBT block. So if you were going to pick a course in focused psychological strategies, if that's the sort of thing you're after, pick a CBT one. Does that make sense? Interpersonal therapy, the basis of all interpersonal therapy is we are the way we are because of the way we relate to others, and if we can improve the way we relate to others, we can improve our mental health. Who are the sort of people who do best, and there's good evidence for this with depression, with interpersonal therapy? Often people who've grown up in environments with really toxic relationships, who keep marrying alcoholics, people who have suffered bullying and harassment at work, people who are very shy and find it difficult to interact with people, victims of domestic violence, anything involving a relationship where the relationship is in trouble, interpersonal therapy is the go. It can occur in a few ways. So there's family therapy where you have the whole family in the room and you look at how people relate to each other. And then there's marriage counselling, which those of us who are old enough who did the family therapy program, we actually taught it in those days. We don't teach it anymore, but relationship counselling, or it might just be one person in a room talking about relationships. These two techniques, CBT and interpersonal therapy, is what you refer to psychologists for, but the focused psychological strategies training give you some tools to do the simpler versions if you want to, and also to understand more deeply what it is the psychologist is actually doing so you can back it up. Those of you in rural and remote that don't have access to a psychologist may really want to do this work, and also there are those of us like me who do this work because 10 sessions with a psychologist may not be enough and you're having to supplement that to keep the patient going. Now, narrative therapy, in my understanding, Bridget, we don't have a course yet on narrative therapy. We're trying to work on that. It's a new addition. Narrative therapy, the idea of it is that the way people tell their stories and the way they craft their stories can change the way they see the world, which you can well understand in Aboriginal and Torres Strait Islander cultures makes a whole lot of sense. So this is getting well through yarning, trying to recraft a story. And a perfect example would be the situation where somebody sees themselves as a failure because everything they've done has turned badly. And you can actually have conversations and turn that around into this person has survived an overwhelming bucket of trauma, and it's actually astonishing that they're upright. And you can get them to recognise the skills and the capabilities that they've brought to their life and how they've actually made a difference. I know that sounds oversimplistic, but that's the guts of it. It takes quite a long time, but it's very useful in Aboriginal cultures. So we're hoping that a course provider will begin to develop these. We have different course providers. They apply to us. Anyone can apply to run a course. We assess it. If it's good enough, it gets up. If it's not, it doesn't. And we're particularly fussy about care and consumer input, making sure that that's meaningful and not just stay for 5 minutes at lunchtime and we'll give you a bit of a chat. Things that aren't eligible to deliver as part of focused psychological strategies or officially to refer for are these. I'll give you a little bit of a summary of the acronyms. So acceptance and commitment therapies, anyone know about that? Yeah, a few people. Okay, you might have heard about that. It's values-based. So the theory behind ACT is that you won't get a grandmother with rheumatoid out walking every day to stop her symptoms getting worse, but you will if you tell her that she wants to play with a grandchild, so she'd better get herself fit. People do things because they're motivated, because it's something they value. And this is about, even if you have the worst pain in the world, if you can work out what you want to achieve in life and focus on that rather than tell me more about the pain, tell me more about the pain, tell me more about the pain, it often makes a difference. This is not to say these therapies have no evidence. I mean, for goodness sake, how much medicine do we practice that has no evidence, let's be honest. This is just to say that this program doesn't fund them. So psychologists will bring some of these in, it's just not part of this program. Does that make sense? Ditto on mindfulness. We know that mindfulness has some impact, but because mindfulness is like saying, I'm giving my patients a pill, mindfulness could be anything to anybody. It doesn't have a lot of evidence behind it at this point in history because everyone does it differently. So again, it might be helpful, it's just not part of this program. And a whole lot of other things. Dialectical behaviour therapy is about distress tolerance for people with borderline personality disorder, and it's usually done in groups. As yet, it doesn't come in under the funding. EMDR is a weird technique that seems to work, but the reason it's supposed to work doesn't make any sense. So, being really honest here, but the technique is that people will watch a stimulus from left to right or listen to a clicker from left to right while they verbalise about their trauma, and it reduces symptoms of PTSD. That is true. However, the person who invented EMDR, their pseudo-scientific explanation of what's happening in the brain while all that is happening is probably not true. So you will see a number of psychologists using this technique in PTSD, and I think it's got some resonances with hypnotherapy, which works with some patients and not with others. So just to give you a little bit of background, but not included. Psychodynamic therapy is about insight, so we're trying to work out if people understand the way they are, maybe they can improve their mental health. So for people for long-term trauma, it's very helpful. Again, may be helpful, but doesn't fit in this. And schema therapy is sort of a combination of CBT and psychodynamic therapy. So schema therapy is about trying to work out what are the underlying roots of why we are the way we are. And it might be trying to understand that we've run our whole lives on the basis that if we're not loved, we're worthless. That might be something. And working on that whole point of view that then brings up negative automatic thoughts. It's like the roots of a tree and the negative automatic thoughts of the leaves, if that makes sense. It's finding the core of why people are the way they are. Again, useful, but not in the regime and won't be taught in this program. Does that help a bit? Yeah, that's not in there either. So neuro-linguistic programming, it's part of interpersonal therapy though, so it probably gets taught. So here's the secret bit. I'm sure psychologists draw on a lot of this stuff while they're supposedly doing CBT and interpersonal therapy, but theoretically they're not supposed to. But you didn't hear that from me. There is, however, if you're interested, and this is really helpful, the College of Psychology, bless them, keep doing this, which is great, which is a book that goes through the actual evidence behind psychotherapies. So if you go onto their website, the Australian Psychological Society, they've actually summarised the evidence, and it's good because it's got a little bit of summary of what each technique is, and you can look up the evidence. So if a patient comes back and says, you know, my psychologist says I need woo therapy or something, you can look it up. And that's actually quite helpful so that you can work out what your local psychologists tend to do. So effectiveness, now I have slight problems with effectiveness because you can only do a randomised controlled trial if something is standardised. So if I see a patient and do psychodynamic therapy and I do different psychodynamic therapy with every patient, you can't do an RCT on that. So things like CBT, which is more directive and manualised, will always have more evidence. Does that make sense? Having said that, the evidence is a little bit overwhelming with CBT. There's a lot to be said for it. There is some evidence for effectiveness across the range, but as I said, it's patchy for some of the therapies. For kids, CBT and behaviour therapy come up the heaviest. With some interpersonal therapy, not surprisingly, because, you know, adolescents, coming up for depression in the adolescent population. And obviously family therapy comes in fairly highly when you're looking for kids. I wanted to spend just the last couple of minutes talking about more broad applications. So if we look at this, this was what the initiative was built for. People come in with, let's say, anxiety, depression, well, mainly anxiety, depression and eating disorders. We assess them, we do a mental health treatment plan, we then get 10 sessions of psychological strategies, or we deliver them ourselves. So it can be either or. And, you know, it's all evidence-based and it all gets better. That's the idea, yeah. However, you and I both know that general practice is not that clean. And if we look at this sort of case, so if we look at a 35-year-old with you know, postpartum with IVF twins and severe postnatal depression who won't see the psychologist and has got childhood trauma and the mother-baby unit's booked out, and once you want to get her started on treatment, there's a whole lot of stuff you could do in that space that would help her get her going until you can get treatment. And that's often where GPs are putting psychological strategies in, just to start people off until the psychologist is free. The reason I put sertraline in there is because the prevailing wisdom is that you should also always do psychotherapy first. Most of us don't agree with that. If a patient is severely cognitively slowed, there's no point sending them to a psychologist. If they can't think and they can't remember, they can't do psychotherapy. You know, there's no point. You've got to get them stable on the drugs first. So I don't agree with that idea that it's always psychotherapy first. When people are cognitively slowed, psychotherapy just can't work. It's like asking someone who's moribund with rheumatoid to go and see a physio. You've got to get the inflammation down before you can do anything. Yeah. So, as GPs, we're often doing three things at once. We've got to make a psychiatric diagnosis, and I quite like the mental health skills training because it makes us go through a mental health state examination, and I actually like that because you often forget to ask the questions about shameful things like OCD and psychosis and eating disorders that patients will hide unless you get triggered. So make yourself make a diagnosis somewhere in there. Make yourself make a medical diagnosis because you feel really stupid if you've been treating them psychotherapeutically and they've got a, TSH of 85. And somewhere in there you make a psychological formulation, and all that is if I was handing a patient over to you and you were going away, I was going away on holidays, I would say, I've got Michelle, she's got IVF twins, she's stressed out of her brain, she's got endogenous depression, and this is what's going on in the family, and at the moment this is what we need to do. And I write that in the notes now. So I write all three. This is what I'm thinking psychiatrically, this is what I'm thinking medically, this is what I think is really going on. Yeah. So what do we deal with that isn't a disorder? We deal with a lot, and this is where it's quite helpful to deconstruct those focused psychological strategies and to just use them in bits rather than using them like they're supposed to be, like they've been funded to be used. So you don't bill them the way that they suggest, but you bill a long consultation and you use them as a tool like you do with everything else. Obviously, we see an awful lot of interpersonal stuff, so interpersonal therapy obviously is really important in here. And we see all this: grief, loss, bullying, domestic violence, sexual assault. We see a lot of crisis. The bitch is community trauma, because usually if there's been a flood through the town, that's affected you too, and it means that every single patient that you see is a bit traumatised, and that's really hard for a local rural doctor. So it's very helpful to actually have some tools and techniques in your toolkit that you can actually use. Behavioural issues are huge in normal people. It is completely normal to struggle with parenting a kid who's a bit different to you, and to try and get more tools in your toolbox and come to the GP and say, I don't know what to do with this 4-year-old. He's acting out at kinder, he's not, mixing with the others, and everything I do seems to make it worse. Help me. So adherence to treatment, the patients who just don't do what we ask them to do, trying to help them with their diabetes or whatever. The smokers and the drinkers and the people who don't exercise and those sort of things, and obviously patients with addiction, gambling included, as well as the other stuff which comes up in diagnoses. We also do this, and it's important to talk about this, even to say it's outside of focused psychological strategies, but it sure is important. When your world is falling down around your ears and everything is going wrong and who you are as a person is being challenged, somewhere we GPs have got to pull up the wisdom out of our boots. When a patient is dying and they've got 4 kids under 10, it's just not darn fair. And we're the ones who have to visit them, who have to live with that trauma and sit there and be there for those patients and try and help them, When I say job loss, I mean the really severe ones, like when the farmer loses the farm that's been in the family for 4 generations. Who is he? What is he as a person? The woman who always wanted to be a mother and has finally accepted she's infertile. The patient who has motor neuron disease or hit by a truck and now has a severe disability and can't do anything that they used to do. That sitting with that existential stuff is really important, and it's important to learn. It's important for us to discuss. You just won't find it in our courses. So I wanted to make really sure to say that I really respect that, and I think it's important, and it's something that we do outside of that focused psychological space. And obviously I'm not telling you anything about adult survivors of childhood abuse who come in with terrible problems that last a lifetime that aren't going to particularly get better with 10 sessions of CBT. So are focused psychological strategies the key for everybody? No. Do they have a good place in our role? Yes, they do. The reason that I'm talking about it now, and I'm after 15 years finally deciding maybe I will get myself accredited, is that doing psychological strategies didn't used to be any more lucrative than not. So if I was charging a 36 as a consultation item number, it would be not much better than charging the item numbers for focused psychological strategies, so I didn't bother. I already had the skills, I couldn't see the point. However, we've just had a new structure coming into the MBS for drought relief, and it's looking like GPs are going to be able to provide telehealth after the 1st of November if they're focused psychological strategies trained. Now, for patients, I think in MM 4 to 7, yep. But so far they haven't specified where the doctor is. So theoretically, it could be possible for someone like me to actually provide telehealth support for people external with the caring GP, the GP who looks after the patient full time, for me to be able to do a telehealth consultation and assist, which we couldn't before. Remember, with focused psychological strategies, though, it's either or. You either use a FPS GP for your 10 sessions, or you use a psychologist for your 10 sessions, or you use 5 with one and 5 with the other, but you can't have 20 in a year. Does that make sense? So the sort of times that I get brought in as often, the patients with fibromyalgia, the patients with severe lupus and depression, the patients with palliative care, because as a GP I sort of get that, and I probably can do that work a little bit better in many ways than a lot of psychologists could. So it's horses for courses, but it has meant that I think I'm thinking a little bit differently about getting FPS trained so that I can actually maybe help a bit, even though I live in Canberra. So, Bridget, stand up and wave. So Bridget is at the booth, and Bridget knows a lot more than I do about the actual process of FPS and has got all the brochures and everything. She's downstairs in the exhibition space. Feel free to catch me as well. Does anyone have any questions? Yes?
Say again about the telehealth thing.
Yep. 1st of November,
Yes.
I believe it's coming out. If the patient is in MM 5 to 7, 4 to 7, so that's small town, rural, the patient can access, the GP who is delivering focused psychological strategies can access telehealth item numbers.
So it doesn't have to be me that's in the whatnot.
That's right.
Yeah.
Exactly. Which
so it
is
can be my
great.
patient that's stuck an hour and a
Yes,
half out of town.
Exactly.
Yeah. Okay.
That's the point. And that's why I think it's actually got real benefit for those of us who care for patients who live, I've got patients who live 3, 4, 5 hours away who come into Canberra because they've got complicated mental health things. Theoretically, I can now do that with them staying where they are, which is just magic. So I don't know the detail of that initiative. We'll need to look it up.
So patient will be in the house, or patient need to come in the GP space?
I don't know. I haven't quite worked out how it all hangs together, but it may be that, the people it's going to most benefit are the patients who see their local GP for the simple stuff, but their complicated mental health, they drive 3 hours to see someone like me. I think that's the situation where it's going to be easier.
So I have trained this one.
Yeah,
But the most farmer, they don't want to come.
yeah,
So that time, if they're happy to ring or talk with them.
yeah, yeah.
So that is.
Yeah. So I don't know, and I haven't deconstructed exactly what the government has said yet. I don't think it's published on the MBS site yet.
There is some information on the MBS site, and I've got the numbers, sorry. So the new numbers are 2729 and 2731. But it is a video conference, it's not just a phone call.
No,
So
the
it needs to
video,
be
yes.
under the telehealth,
So
yeah.
Skype is allowed?
You'd have to
Yeah.
contact the MBS to talk about that one, yeah.
Yeah.
Same as the wording for the telehealth one.
Yeah.
It's just or psychologist has to include video
Yeah.
of any type.
Yep.
Could be Facebook.
Yeah. So this is, as I said, I've changed my opinion. I think, we've got opportunities now that we didn't have.
Is there a list or a way of accessing GPs who don't have focus?
Yep, Bridget's got it. Yes.
So we can give information about numbers who have trained in certain areas and postcodes. At this stage, we can't give out personal information, but that's something we're looking into.
So, yeah, but what I would do is push your PHN.
Yeah, so we do give that information to the PHNs as well. So yeah, they
So,
should.
yeah, because the PHN should know who the GPs with special interests are. Yep.
Sorry.
So you're saying that if my patient who doesn't have decent internet at home on the farm comes into town to do their shopping, they could Skype me while they're in town?
Yep. I think so.
Could I do this thing while they're in my rooms when they come for their once in 3 months checkup?
Well, if they come for their once in 3 months checkup, then you wouldn't use that item number, but you would use one of the others. You could do the
That's
two.
more
Yeah.
lucrative.
So there's focused psychological face-to-face item numbers,
Yep.
and there's focused psychological telehealth item numbers.
And you were saying about the focused psychological face-to-face numbers, they're not much different than a 36.
They didn't used to be, but they're starting to change.
Right.
The MBS review has
Okay.
made them a little bit more lucrative. I mean, it's not great. They're still, you're still better off taking off an ingrown toenail, of course.
And they're still time-based?
Yeah.
Yep.
Yep. We've tried. And that's one thing the Mental Health Standards Collaboration has worked really hard on, is trying to kick that MBS review into understanding exactly how important this stuff is. And how wrong it is that it's considered more worthy of community money for me to take off a skin cancer than it is for me to, spend a couple of master's degrees and a PhD trying to work out how to treat mental health and, earn the same as I would talking to someone about a cold. So we've tried really hard to get that message across, and we're making inch by inch progress, but we accept it's not great. We're doing our best on that one in advocacy. I would seriously suggest, if you're interested, talk to Bridget, because she's got a lot of materials, and the Mental Health Standards Collaboration, we do make sure anything on the website is a good course. So, you don't want to waste your time. It's hard enough getting to courses, let alone going to a course that doesn't help you out very much. There are a few FPS courses that are available by a distance, so you can do some of these online. So it's certainly worth considering. Or catch me over today or tomorrow and you can ask anything. Yep. Otherwise, I'm letting you go for lunch, I think, aren't I? Am I?
Yep,
Yes.
that's right, lunchtime. Yep. Thank you, Louise.
No worries.